All right, I think we're going to get started in this evening's session on discoveries of new pathways in MS. I am Bruce Trapp from the Cleveland Clinic, who's chairing this session. I'll make a few opening comments, and then we will have three lectures by Dr. Amit Bar-Or, Dr. Rudik, and Dr. Gold. I'm first going to discuss or put into perspective some of the aspects of understanding the pathology of multiple sclerosis. And I'm going to start by making a few comments on the disease which I think are important. The first, and no surprise to the clinicians here, that the clinical course of this disease is variable and unpredictable. We like to refer to it as a very misbehaved disease. Second point, and I think this is a take-home message for MS clinicians, is that much of this disease is clinically silent. So one of the challenges you have as clinicians is convincing invincible young people to take therapeutics that are not very pleasant to take. These young invincible people, that's a challenge you're presented with, and I think it's one that you need to take seriously and try to meet. Finally, we don't fully understand the pathogenesis of this disease, nor do we know whether MS is a single disease or a common endpoint of multiple disease etiologies. Now, despite this clinical variation, most MS patients, and by most I mean 80 to 85%, have a biphasic disease course which begins with the relapse and remitting stage that eventually transforms into a secondary progressive. We have a very good understanding of the pathological aspects that contribute to the relapses in MS, the disability, and these are inflammatory, demyelinating lesions within the white matter. And of course, MRI has given us a very good look at this. It's also this MRI that helps prove the point that much of this disease is clinically silent, and that MR lesions outnumber neurological attacks by as much to 10 to 1 and can be much greater in some instances. So it depends where the lesion is. If it hits an articulate part of the CNS, there will be disability. But there's many parts of the CNS where a lesion can occur where there's not an immediate readout. Now, whereas these inflammatory lesions are good an explanation of the disability that occurs in the relapses, they are not a satisfactory explanation for the continuous irreversible disability that occurs in secondary progressive MS. And there's many things that support this notion. First, many patients continue to decline neurologically in the secondary progressive stage of the disease without any evidence of new inflammatory lesions as measured by MRI. They have no gliocytosis in the CSF. And probably most importantly, they don't respond to anti-inflammatory therapies. So there are additional explanations that explain this continuous disability, and I think now there is a consensus that a major contributor to this permanent neurological disability is axonal and neuronal degeneration. Three environments where this occurs have been described in some detail. First, axons are transected during the inflammatory demyelination. We now know also that MS is not a disease restricted to the white matter, that there's cortical and deep cortical or deep gray matter demyelination, and along with this we have neuritic transection and neuronal death. And finally, we know that myelin provides trophic support that is essential for survival of the axon, and if we remove this myelin, not just for years, but decades, as happens in MS brains, that these chronically demyelinated axons will degenerate. Now, the question of the year, quite common, is MS an immune-mediated or a neurodegenerative disease? And we will not give you the answer to that tonight because we do not know the answer to this question. Probably a more important question is whether, to me, is whether MS begins in the central nervous system or the periphery. And I think we won't tell you that either. But I want to show one data slide which puts the question in perspective. And that involves a cortical lesion that we call a type 1 cortical lesion. And this is a slide of that. It's stained for myelin, so the dark part is white matter, here's gray matter, and here's a lesion. The green lines demarcate the white matter from the cortex, so it's a leukocortical junction. So there's the gray matter lesion. There's the white matter lesion. I'm going to show you a serial section now that's immunostained for MHC class II, the marker we use for infiltrating immune cells. And this is the next section. And what you can see here is that there's tremendous cellular infiltration into the white matter portion of this lesion, but not into the gray matter. And here you see the two serial sections. Now we believe that the age of the white and the gray matter portion of this lesion is similar. So here we have demyelination without inflammation. And by inflammation here, I mean hematogenous cells coming in from the periphery, demyelination in the white matter with severe infiltration. So MS is both an immune-mediated disease and a neurodegenerative disease. We want to stress that inflammation is a major contributor to neurodegeneration. If you reduce the inflammation, you will reduce the neurodegeneration. Inflammation is complex, but remains an attractive therapeutic target. So there's no inflammatory cells, or not many inflammatory cells coming into those cortical lesions, but certainly that doesn't mean that inflammatory cells or immune cells aren't important in initiating and driving that demyelinating process. Finally, new approaches are needed to protect the axons and promote remyelination, and these are additional therapeutic targets to anti-inflammatory therapies. So what are the challenges? The challenges are to identify new and approachable therapeutic targets, more convenient treatment in the disease, particularly oral delivery, personalized treatment, that is, we need to identify responders and non-responders to current and future therapies. And we need imaging modalities that detect myelin. We do not have at this time reliable MRI methods to tell us whether a lesion in the brain is demyelinated or not. Novel targets, the immune system, there's still plenty of work to be done there. One example is B cells. Stock in B cells is going up dramatically in MS. How they're regulating inflammatory lesions, a very important issue. Whether they're driving these type 3 cortical lesions, also an important question. Neuroprotection, will we have therapies that are going to be neuroprotective? There are some examples now, the NERV2 pathway, and there is a clinical trial in the United Kingdom on sodium channel blockers. Repair, there's a lot of work being done on LINGO, some other small molecules that are trying to enhance the remyelinating process. And are there potentially therapeutics to stop?